Hi, my name is Trang and I'm a student pharmacist. Today I will be talking about the Heparin drip update of 2020. The objectives include highlight the new changes and updates in the heparin infusion protocol, recognize the importance of drawing accurate APTT labs, discuss briefly the reversal for heparin, which is protamine, and recognize the importance of anticoagulants as high alert medications. So we have the front page of the weight-based heparin infusion protocol to the right, and the front page includes updated indications for therapeutic heparin drip, stat initial coagulation, and CBC labs for all patients. There is an additional lab section where we talk about major changes when drawing APTT levels. The initial APTT 24 hours check is something new that has been added for patient safety. There is the initial heparin bolus and initial maintenance infusion with maximum bolus and rates, and also a new major addition of choosing between two different heparin drip intensities. This is the backside of the heparin drip protocol, and it has an area where the physician must indicate the heparin drip intensity. The no IV rebolus section is added for high bleed risk patients. The standard intensity on the left is similar to the previous heparin drip protocol, keeping the same APTT goal of 46 to 70, usually used for ACS. The right side is the completely new high-intensity heparin drip protocol with a higher APTT goal of 60 to 90, usually used for VTE or other thrombus indications. Note that the heparin rebolus dose varies depending on intensity. Our max dose for rebolus will be 5,000 units, and we're going to obtain 2 consecutive therapeutic APTTs before checking a daily level. Lastly, there is a section about perioperative management of heparin therapy and other additional orders. Okay, so let's take a closer look. This is the top left of the infusion protocol. You're going to put the date and time, and the physician must check off the indication. Make sure you also check for any contraindications with heparin, such as a history of heparin-induced thrombocytopenia or HIT thrombus, known true allergy to heparin or pork products, history of large bleed in the last 30 days, or any active bleeding. Please make sure to notify the physician if any active bleeding was observed prior to starting the heparin drip. If the RN is entering the order for the physician, the RN must clarify the indication, if initial bolus will be given, which intensity, standard or high, and if there will be any rebolus or not. You're going to use actual body weight, which is in kilogram, so if you have pounds, make sure to convert it into kilograms. So just to quickly recap from the last slide, what are the 4 questions that RNs must clarify with the physician if heparin drip order is to be entered by the RN for the physician? You can remember the answer to this question by remembering the triple IR. And the triple IR stands for indication, initial bolus or not, intensity of heparin, standard versus high, and R for rebolus or not for high bleed risk patients. Right when the physician orders a heparin drip, you should order stat baseline labs if there are no available labs within 6 hours of starting the heparin drip, and these labs include APTT, PT, INR, and CBC. If baseline coag labs are abnormally elevated, make sure to notify the physician immediately. The heparin drip may be started as soon as baseline labs are drawn, or if baseline labs were already available within 6 hours. You must wait for the lab results before starting the heparin drip if the patient has end-stage renal disease, chronic liver disease or liver failure, or if the patient is on any outpatient anticoagulant. So this slide is a practice case. A 60-year-old male with cardiac history came into the ER complaining of shortness of breath at 0600. His weight is 100 kg. The ER physician ordered standard baseline labs, Chem 20, CBC, cardiac markers, and coag labs upon admission. Later that afternoon, around 1500, the patient developed chest pain. An EKG showed end-STEMI, vitals, LFTs, and H&H platelets stable. No bleeding observed. The patient was interviewed and stated that he was not taking any anticoagulants prior to admission. The physician ordered heparin drip per ACS protocol. Start with initial bolus, standard intensity with reboluses since the patient had low risk of bleeding. According to the new heparin drip protocol of 2020, when should the physician or RN have to order new stat baseline labs? Remember, baseline labs must be drawn within 6 hours from starting the heparin drip unless the physician orders otherwise. In this patient case, stat baseline labs should be ordered prior to starting the heparin drip because it has been greater than 6 hours since the previous lab was drawn. Okay, so the next question is for the same case. According to the new heparin drip protocol, can you initiate the heparin drip once the stat new labs are drawn at 1500? The answer is yes. You may initiate the heparin drip safely without waiting for the repeated labs results since the patient is not ESRD, has no liver issues, and did not take any anticoagulants. The patient has a lower bleed risk overall. This patient clot risk is actually higher than their bleed risk, so heparin can be initiated, but of course the physician may also order otherwise. In this next slide, we will be going over initial APTT labs. It is important to note that baseline APTT is not the same as initial APTT. Baseline APTT is drawn before heparin is given, and initial APTT lab is drawn after heparin administration. If an initial bolus was given, the initial APTT will be drawn in 6 hours, and if no bolus was given, then it will be drawn in 4 hours. This next part was added for our patient safety. There will be an initial 24 hours APTT check every 6 hours apart. Ideally, this would mean APTT would be checked 4 times in that 24-hour period, but realistically, this may not be the case due to logistics and lab turnover time, so you may fit at least 3 APTT levels in that first initial 24 hours. The new heparin protocol also indicates to obtain 2 consecutive therapeutic APTT labs every 6 hours, and then it can be checked daily with AM labs at 0500 instead of 0600 to avoid high volume turnaround time. Make sure to order initial APTT labs as timed and monitor H&H platelet trends as per physician order. So here are some considerations for when drawing a lab. If it's drawn from the opposite arm, there is no need to turn off the heparin drip infusion, but if it's drawn from the same arm, you must coordinate with lab and turn off the heparin drip infusion for 5 to 10 minutes only. Since heparin has a short half-life, holding it longer than 10 minutes will affect the lab results. So if it's held longer, please notify the pharmacy and also document the length of time heparin drip was held, when and where the lab sample was drawn. Also, if applicable, please disregard the first test tube and keep the second test tube to be used for testing. If drawn from a PICC line, make sure to flush with NS to avoid heparin contamination, and also to avoid drawing lab from the feet unless order was obtained from the physician. So continuing with the same practice case, initial heparin bolus IV was given at 1510, and heparin drip was started at 1515 on August 14th. At what time should initial APTT be checked? Since heparin bolus was given, the initial APTT should be checked 6 hours after, so it should be drawn around 21:15 of August 14th. Remember, if no bolus was given, APTT should be checked 4 hours later. For this next question, assuming that lab turnaround time is 1 hour, how many labs, not including baseline, do you need to obtain before APTT can be checked daily? So remember, the initial 24-hour check with a 1 hour turnaround time may fit up to 3 APTT levels 6 hours apart. And since you need to obtain 2 consecutive therapeutic APTTs before checking daily levels, then if the last 2 APTT levels within the initial 24-hour check were both therapeutic, then you can start checking daily levels thereafter. If you do not have 2 therapeutic levels within the initial 24-hour check, please keep checking every 6 hours until this is achieved, then start checking daily levels after. Note, the pharmacist or physicians may adjust the protocol to the patient's response. So let's say the initial APTT at 21:15 value is 46, APTT at 04:15 is 55, and APTT at 11:15 is 60. When should the next APTT be checked? Let's break the problem down visually so that we can answer the question. Baseline APTT was drawn at 15:05 on August 14th, and the result came back to be 28. Heparin bolus and drip was started around 1515. The problem also stated that the initial APTT at 2115 value is 46, the next APTT at 0415 is 55, and the next APTT after that at 1115 on August 15th is 60. Please note that these three APTT readings falls within our initial 24 hours check, and the next APTT level, which will be in 6 hours from our last reading at 1815, will fall outside of the 24 hours check. So given this information, when should the next APTT level be checked? Remember, the initial APTT check is in a 24-hour period, and you also need to obtain 2 consecutive therapeutic APTT level before it can be checked daily. A total of 3 APTT level met the criteria for the 24 hours initial check, so luckily the last 2 levels were also consecutively therapeutic and no further tests are needed, so you can obtain daily levels after. If the last 2 levels were not therapeutic, then you would have to keep checking every 6 hours until you obtain 2 consecutive therapeutic levels. So the answer to when you should check the next APTT level should be on August 16th at 0500 if possible, and this is to avoid the delayed results from shared volume of AM labs at 0600. Additional orders included in our new heparin protocol is to discontinue duplicate anticoagulation such as sub-Q heparin, Lovenox, or fondaparinux before starting the heparin drip. If any dose of anticoagulant was already given, and this includes outpatient anticoagulant, please notify the physician immediately. If the patient already took oral anticoagulant, such as warfarin, Xarelto, or Eliquis, before the heparin drip was started, make sure to notify the physician immediately as well as document accordingly. If a patient is transitioning between anticoagulants, the pharmacy may be called for recommendations. Please remember to avoid IM injections. It is very important to assess and document for bleeding or clotting during every shift in the electronic health record. Please also note that there is a new section for nephrology consult for ESRD or stage 5 CKD patients. This is the top right of the protocol, and here we have the loading dose of heparin, which is different based on indication. So the top one is DVT-PE, and you can see that it's 80 units per kilogram with the maximum dose of 10,000 units. The bottom one is the ACS-MI, which is 60 units per kilogram with the maximum dose of 5,000 units. Please make sure to order heparin bolus as an IV route because this is an example of when heparin was entered as subcutaneous. No heparin boluses are needed for patients with an INR of 1.5 or greater. If they have end-stage renal disease or high bleed risk, please make sure to inform the physician if INR is greater than 1.5 and consider no initial bolus if another anticoagulant was recently given to the patient. To avoid duplicating anticoagulant therapy, the physician should be notified immediately if this was discovered. Then the bottom will be the initial heparin maintenance infusion. There are 2 different intensities, and this is the major change that you need to pay attention to. So for the standard intensity protocol, the goal APTT will be 46 to 70, which is for indications like ACS or MI. The rate will start at 12 units per kilogram per hour with a maximum rate of 1,000 units per hour. And then for the high intensity protocol, the goal APTT will be 60 to 90 for indications like DVT or PE, and the rate will start at 15 units per kilogram per hour with a maximum rate of 1,500 units per hour. There is another section there that if a physician wants fixed rate or if they have different goal for APTT, you can also fill this out as well. The premixed heparin solution comes in a standard concentration of 50 units per ml, and we have D5W or half NS, which is the preferred one for diabetic patients. Here is the continuation of the same practice case previously mentioned. So what is the calculated initial heparin bolus dose? Since the patient weight is 100 kg and the bolus dose is 60 units per kilogram for the ACS indication, this will equal to 6,000 units. However, remember there is a maximum initial bolus dose for ACS, which is 5,000 units. So the correct answer here would be 5,000 units should be given intravenously for our patient. The next question asks, what is the calculated initial maintenance infusion rate? So given that our patient weighs 100 kg and the ACS initial rate is 12 units per kilogram per hour, this will equal to 1200 units per hour. However, our maximum initial rate for ACS is 1000 units per hour. So our answer is actually 1000 units per hour divided by our 100 kilogram patient. This equals to 10 units per kilogram per hour as our initial infusion rate. So this is the backside of the heparin drip protocol. On the top, you'll see a yellow arrow pointing to where the physician must indicate the heparin drip intensity. The red arrow below it points to the no IV rebolus doses. This is reserved for special cases where patients are sensitive to anticoagulation or have high bleeding risk. So please clarify with the physician if this is what they want. Another thing is that if this is checkmarked, I highly recommend nurses to notate this in the EHR, MAR, or even cross it out in the titration protocol so that it is clear there is no rebolus for the patient. This is the titration part in detail. Standard intensity and high intensity with indications and goals are listed at the top. For our standard intensity, if APTT is less than 25 to 35, then the rebolus dose will be 60 units per kilogram with a maximum dose of 5,000 units, and the IV rate will increase by 4 units per kilogram per hour. Labs will be repeated in 6 hours, and if APTT is 36 to 45, the rebolus dose will be 30 units per kilogram with the same maximum dose of 5,000 units, and the IV rate will be increased by 2 units per kilogram per hour, and the labs will be repeated in 6 hours. Again, if two therapeutic APTT levels between 46 to 70 has been achieved within 6 hours apart, then labs can be repeated daily. If APTT levels are high between 71 to 90, the IV rate will have to be decreased by 2 units per kilogram per hour and check labs in 6 hours. If APTT falls between 91 to 130, decrease rate by 3 units per kilogram per hour. For APTT between 131 to 160, the rate will be decreased by 3 units per kilogram per hour, which is the same for our high intensity on the right. And if APTT is greater than 160, you will need to stop the IV infusion and notify the physician immediately. You would then need to check APTT level every 2 hours until it's less than 100, and when it is less than 100, decrease the rate by 4 units per kilogram per hour from the previous rate. Then check APTT in 6 hours. Note that this is the same for our high intensity on the right. On the right side for high intensity, if APTT is less than 25 to 35, the rebolus dose will be 80 units per kilogram with the same max dose of 5,000 units, and the IV rate will be increased by 4 units per kilogram per hour with repeated labs in 6 hours. For APTT readings between 36 to 45, rebolus dose will be 40 units per kilogram, and IV rate will increase up to 2 units per kilogram per hour. There will be no rebolus if APTT falls between 46 to 59, but the rate will still increase by 1 unit per kilogram per hour. For our high-intensity protocol, our goal APTT is 60 to 90, and if this is obtained 2 times every 6 hours, then labs can just be checked daily. The no rebolus is slightly different from our standard intensity. If APTT is 91 to 130, decrease the rate by 2 units per kilogram per hour, and if APTT is 131 to 160, the rate is decreased by 3 units. Again, please make sure to stop the infusion and notify the physician immediately if APTT is greater than 160. Lastly, the bottom portion is a summary of important information that you will need to remember. Again, there are 2 different goals for our standard versus high intensity. Our heparin IV rebolus max dose is 5,000 units. Make sure that you are using actual body weight and also round up your APTT results. Perioperative management of heparin therapy is very important. So if your patient is on any anticoagulants, you should always think and plan around procedures because they may have to be held and restarted depending on the patient's bleed or clot risk. So for heparin drip, it's recommended to discontinue IV heparin 6 hours before surgery. Again, this can vary depending on the type of surgery that they have, so it's very important to clarify it with the physician. Heparin therapy is usually restarted 6 hours after surgery if the patient is hemodynamically stable. Please use the most recent infusion rate without the bolus and obtain APTT 6 hours later. Then follow the heparin drip titration protocol. Also, additional orders on the right include adjusting heparin drip based on the standard or high intensity. This may change before and after the procedure, so clarify it with the physician. I highly recommend that you enter the plan as a nursing order if the physician did not order one, and document the plan in your notes. You must also document using the heparin infusion monitoring flowsheet in the EHR because it must be trackable. Lastly, refer to protamine and heparin reversal in GMH policy 1309J or just call pharmacy for any recommendations. So with protamine used to reverse heparin, the dosing is based on how heparin was infused. The max dose for protamine is 50 mg with a max rate of 5 mg per minute. You may give another protamine at a lower dose, but please be cautious because protamine is a weak anticoagulant. It is administered via IV push or IV piggyback. IV push or infusion need to be given slowly due to hypotension or possible hypersensitivity reaction. Please make sure to repeat APTT labs 15 minutes after the reversal is given. This next slide pretty much summarizes everything in our new heparin drip update. The overall goal of this new update is to improve turnaround time for initiation and titration for heparin drip. Our goal for turnaround time is within 1 hour, and hopefully this will improve patient care and minimize further clot or bleed risks. I want to highlight again that you need to obtain clear orders for heparin drips. Remember the triple IR that we talked about, which is indication, initial bolus or not, intensity of heparin drip, or rebolus or not. Also, make sure there are no duplicate anticoagulants given before starting heparin drip, especially since there are different EHR systems in use. When ordering heparin, make sure to order a stat level for baseline APTT, if none available within 6 hours before starting the heparin drip, and order time levels for all other APTT levels. Please make sure to check APTT promptly. We need to make sure that heparin infusion is traceable because this is required by JCO and is part of the NPSG, which is the National Patient Safety Gold Standards. We can do this by using the EHR heparin monitoring flowsheet. Please make sure to document and endorse any bleeding episodes and also to obtain and document clear orders for procedures into the EHR. If heparin was held, discontinued, or restarted, please make sure to update the status in real time and also to document in your notes when patients are transitioning between anticoagulants. Remember that you can always give the pharmacy a call and ask for recommendations on what steps to take next if you are unsure. Lastly, this slide stresses the importance of monitoring and documenting administration of all anticoagulants in patient notes because anticoagulants are considered high alert medication per the Institute for Safe Medication Practice, which means that they have a heightened risk of causing significant patient harm when used in error, so please make sure to document the use of anticoagulants in your patient notes. Lastly, let's go over a few commonly asked questions nurses may have regarding the new heparin drip protocol. The first question is, when should you draw AM APTT levels? At 0500 or 0600. So you want to obtain morning APTT levels at 0600 for all wards except for ICU. Morning ICU APTT levels should be obtained at 0200. Please keep in mind that pharmacists may make interventions as needed. For questions number 2, lab considerations. If drawing from a pig line, discard 3 to 5 milliliter and make sure to flush with NS before obtaining blood specimen to avoid heparin contamination. So is this the same way with central line drawing? The answer is yes, always flush with NS. If appropriate, discard 3 to 5 millimeter before obtaining sample. For question number 3, what should you do if you have patients whose weight have significantly changed after the heparin drip has been started? The answer is to use the rate that is based on the initial weight if heparin drip has already been started. The weight will be changed or updated when a bolus is required. Since the titration of drip is based on the current rate and patient's response, adjusting the pump with the most updated weight may not be necessary. If weight of the pump is to be changed, then the RN or the pharmacist should document in the notes, or the rate may be back calculated by the pharmacist. For question number 4, will the pre-op and post-op surgeon, IR, or OR staff be responsible managing perioperative management of heparin drip, or will it fall to the attending physician or primary nurse? The answer is that surgeon or IR physician should be the ones to decide how long to hold prior and resume heparin drip after the procedure. Ideally, there should be communication between both attending physician and surgeon or IR physician in the management of the anticoagulation. Clear orders should be entered into the EHR. If no clear orders are entered, then primary nurse and OR or IR nurse may need to obtain and clarify orders from the physician. Question number 5. With the new heparin guidelines 2020, it has 2 intensity orders, the standard intensity and the high intensity orders. Is this video training for physicians as well? The answer is yes. The current video is also applicable for physicians to watch. There is no video training specific to physicians at this time. For question number 6, will the standard and high intensity order of heparin be placed in the CPOE? Yes, physicians should enter complete orders regarding bolus or no bolus and indicate standard or high intensity of every heparin drip. Question number 7, are there any paper forms for the heparin orders, or is it via EHR? So paper version of the heparin drip order forms may be obtained from GMHA physician form website, and here is the link. For the last question, since nurses and not the physician enter the heparin bolus as a telephone order via the EHR, what should happen if a heparin drip order is unclear? So for every heparin drip order, if not clearly indicated, heparin initial bolus and rebolus needs to be clarified with the MD prior to starting the order. Thank you so much for your attention and have a nice day.